Friends, a very good afternoon. Well, PFN or the intramedullary implant is the implant of choice for unstable fractures, which do include reverse oblique, transtrochanteric, large postmedial fragment, and subtrochanteric extension, as mentioned by my previous speaker also. Well, it is a good implant, it is an ideal implant, it should be for these conditions, but the learning curve is a little longer, but if you master it, then things become very easy. The common errors which can occur could be wrong positioning, faulty draping, and it is listed in front of you. These are all practical tips. I'll try to cover them one by one. The wrong positioning. By positioning for PFN, a closed PFN, we intend that trochanteric area must be easily accessible to the surgeon. For that, when the patient is lying supine on the fracture table, adduct the affected limb and trunk to allow access to the trochanteric area, like shown in the diagram. One has to abduct and maybe flex the unaffected limb to make the position of the intensifier easier. To ensure an absolutely ideal positioning, strap the arm across the chest of the patient, put a folded towel below the affected gluteal area and push the fat pad medially. Side support just below the axilla at the level of the thorax to put it towards the other side, and now you can see from the photograph how nicely the trochanteric area is available to you. These are small tips, but they can matter a lot in a particular case. Now, draping. There are a few problems with the draping. These are all practical tips. Avoid encircling the thigh with the drapes. Multiple folds of drape and towel clip in the line of the skin incision makes entry difficult, like you see in this patient. These are the actual photographs. I'll tell you why these photographs were taken. Because once these drapes, the drape folds will ultimately impinge and push upon the tip of the instruments medially, particularly the bone awl. Once they push the tip of the instrument medially, the trajectory is lost. This is an actual photograph of a case taken when one of my junior colleagues called me to help him. I mean, once you keep on pushing, this is what happens. A lot of blood loss and you are going only medially. So please ensure that there is a squaring of the operating site with the drapes. Extend the sterile field well above the LA crest and avoid drape folds proximally with no towel clips in the line of the skin incision as shown in the photograph. Now we need to have an excellent imaging during the whole procedure. The whole thing is dependent initially on the imaging only. This is supposed to be the correct position. One very practical tip about which no books has written, that for simple fractures where the fragments are lying parallel to the ground, normal AP and the lateral views give satisfactory images as shown in the photographs. You can see we are taking a bone model to demonstrate. But in cases of subtrochanteric extension of the fracture, the proximal fragment is flexed, abducted and external rotated. Hence it is lying in an oblique plane. Placing C-arm in conventional AP and lateral position gives oblique views. Let us see an example. If the proximal fragment is in a mal position, in a case of subtrochanteric extension, normal AP view gives oblique images. A practical tip, please try placing the C-arm in an oblique plane and then you will get a true AP view. Same thing would happen with the lateral view also. This is the lateral view which is present when the proximal fragment is in a mal position. If you take the C-arm in an oblique position, you get a perfect lateral view. So adjust your C-arm, particularly in cases in which the proximal fragment is rotated. Now, errors in the entry point which can occur. The entry point is supposed to be just medial to the tip of the greater trochanter, as shown in the bone model. Place your incision 2 finger breadths above the greater trochanter and never at the tip of the trochanter. Once you are away from the trochanter, one can have a vertical trajectory to the shaft of the femur. If the incision is just at the tip, then you are likely to go medially, like this. Now there are several points which are important for the entry point. The patient's limb position, soft tissue mass, the operative drapes, the trajectory of the reamer insertion, and the nail insertion can gradually enlarge. If you are not careful about these points, then the entry holes get enlarged, leading on to more lateral placement of the intramedullary nail or the PFN nail. Once the entry point becomes lateralized, then the fracture gets fixed in a varus position, which can ultimately give rise to failure of the implant. If we are not careful, then the entry point could be medial also. This is a lateral entry point, and one can have if the entry point is not correct, then one can have a medial entry point also in which the fracture would be fixed in the valgus position. Both of these positions are bad. The lateral entry point as well as the medial entry point. Now a very practical tip. Most of our friends in the practice, they are forced to use local implants, local instruments because of the cost factor. Now please note that the end bone should be well away from the tip of the instrument. Both of these things are available in the market. One has to be careful in choosing. What would happen if the tip of the bone awl and the handle are almost in the same plane? Then the handle is likely to touch the drapes and the patient, and again you will go medially. If the handle is away from the tip, like as shown in the photograph, then you are in the center. So very practical tip, the handle of the bone awl should be well away from the tip. Well, the pertocrantic fractures should always be reduced before inserting the guide wire. They are different from the diphyseal fractures. We are in the habit of having that notion that once you put in a nail, intermediate nail, even if the fracture is slightly displaced, it will fall in position. But a trochanteric fracture with a subtrochanteric extension will never fall in position. It will remain in whatever position you fix. So please reduce before you actually start inserting the nail. I think I have to hurry up. This is a small tip of the method of reduction. Then as far as reduction is concerned, one must be sure that the fracture should not neither be in varus or in valgus. If the tip of the trochanter is lying as collinear with the center of the head, then it is the perfect position. Otherwise, if it is in varus position, when the tip of the great trochanter is above the center of the head, and if it is the tip of the great trochanter is below, then it is valgus position. Both of these things are bad. My previous speaker has talked about this thing. I will not go into detail. Only thing is that the head position, the leg screw should be just within 10 millimeters of subchondral bone and exact in the center. Otherwise, we can have a Z effect. Well, we must understand that this anterior bow of the femoral shaft, one shall never push a nail into PFN. If you have to hammer a nail, it means there is some obstruction, and one must take a view at the tip of the nail. Length of the nail, whenever in doubt, please use a longer nail. These are pathological fracture, like osteoporotic bones are always pathological, always use a longer nail. To conclude, take extra care for positioning and draping, accurate imaging, reduce first and fix later. Entry point should be just medial to tip of the trochanter. Be careful about the level of incision, accessible trochanteric